introductory message by Professor Asiri. Is he around?
Yes.
Could you please deliver your message? Thank you very much.
Okay. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير. Good evening everybody. وكل عام وأنتم بخير. It gives me a great pleasure to give this introductory message on the Saudi Pediatric Association, which is SPA, which was established in 1981 by our late Professor Hassan Kamil, who was the first Dean of the Faculty of Medicine, King Saud University. The College of Medicine, King Saud University, was the first college which was established in the Kingdom of Saudi Arabia. The board member of SPA is Dr. Abdullah Lumier, who is the president of the SPA, and the other board member representing other healthcare provision in the Kingdom of Saudi Arabia, like Dr. Abdulaziz Touaim, who is the vice president of the SPA, who's representing the National Guard Health Affairs, and Dr. Muad Tureki, who is the secretary of the SPA, who represent Ministry of Health. Professor Muslim Al-Saadi, who is the head of the scientific committee from College of Medicine, King Saud University. Dr. Khalid bin Birik, who is the treasurer of the SPA from College of Medicine, King Saud University. Professor Saad Al-Saadi, who is the consultant neonatologist from King Abdulaziz University. Professor Abdurrahman Al-Sultan, who is consultant and professor of pediatric hematology and oncology from King Saud University, and Dr. Ahmed Balkhair from Ministry of Health, and myself. Of course, the founder, as I mentioned, of the SPA, it was founded by King Saud University. Before it was called King Riyadh University in 1981. The objective of SPA is development of pediatric principle, practice, professionalism and clinical skills of pediatric and other healthcare professionalism. The vision of SPA is to be a pioneer in continuing medical education and research in pediatric, and the mission of SPA is to serve the community through development of professional pediatric practice, health education, and child health service. And the slogan of SPA toward excellence in pediatric medical knowledge, practice, and service. The SPA is a member of Union of Arab Pediatric Association, is also a member of the Union of the Middle Eastern and Mediterranean Pediatric Society and the International Pediatric Association. The SPA, of course, has a lot of activity which serve the community. It obtained, it was given or honored by the vice dean, by the vice rector of the university for the scientific research and postgraduate studies in the quality as the classified as grade A. Of course, it carried a lot of conferences and symposia in different cities of the kingdom, in Riyadh, in Jeddah, in Medina, and in Yambo. This is just some of the conferences which was carried by the SPA. And of course, Dr. Abdulaziz Touim has great impact as organizer of this, conferences, particularly in Jeddah, Medina, and Yambo. I would like to thank really Dr. Touim for the great effort of organizing these conferences, and also the other conferences on endocrinology, education in diabetes. And of course, SPA also organized some postgraduate courses for the Arab board and Saudi board resident and for the MRCP, and also organized other postgraduate courses like the Middle East course in pediatric gastroenterology. This is some of the conferences which was also organized by SPA. I would like to thank in advance all the speaker and the organizing company. I would like also to thank Dr. Abdullah Umair, the president of the SPA, and my colleague, the other board member. I would like also to thank Dr. Touim for this organization. Initially it was endocrinology, but now there is other, of course, activities in pediatric. Like tonight, we are going to have pulmonology, immunology, and I am very pleased to see Dr. Skandarani, my colleague in Saslugan in pediatric gastroenterology. Thank you very much.
Thank you very much, Professor Asiri, for this comprehensive talk about the Saudi Pediatric Association. It's my pleasure to introduce my dear colleague, Dr. Rafat Musalli. He is an associate professor of pediatrics at Al-Qura University, and he's also the head of neonatal and pediatric ICU at the International Medical Center. He has a long and comprehensive history of training abroad. He has done an American Board of Pediatrics as well as the Canadian one. He has finished a fellowship in pediatric and neonatal ICU at McMaster and Ottawa University. He's a fellow of the Royal College of Physicians and Surgeons of Canada. And he has also done something extra, a medical quality management by the American College of Executive Board. And currently he's a Sibahi surveyor. Dr. Rafat is going to talk to us about infant feeding at the time of COVID-19, setting realistic standards. Dr. Rafat.
Thank you, Professor Naufal. Good evening, everybody. Thanks for inviting me, board member, chairman, dear colleagues. Good evening, and I'm so glad to present today an important topic, which is the infant feeding during the COVID-19. Is it obvious now?
Yes, yes.
Okay.
Wonderful.
So, Bismillah ar-Rahman ar-Rahim, Alhamdulillah Rabbil Alameen, wassalatu wassalamu ala ashraf al-mursaleen, Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. So in the 20 minutes, though is short, I'll try my best in order to make it brief for you and to highlight the evidence-based medicine around the infant feeding during COVID time. The pandemic is quite a stressful time for not only for the healthcare providers, but also for the parents who are expecting or who are birthing a baby with suspected or confirmed COVID. The concerns have been raised since the beginning of the pandemic and whether the mother with COVID can transmit the virus to their infant through the breastfeeding. The recommendations, unfortunately, regarding the mother-infant contact and the safest way to feed their baby is quite limited. Therefore, a decision and approach with an evidence-based sounds need to be taken in order to get the most safest way to get the baby fed. So what I'll try to do in the following 20 minutes is to review the current evidence, and I will promise you I'm not going to go in details. I'm going to give you just the essence and the conclusion. And at the end, or the second half of the discussion, we're going to draw the evidence-based decision and approach with the realistic goals, how to feed infants with suspected or confirmed COVID mother. So before I start, I just want to give you a survey question, and this is nothing wrong or right about this. I just want you to share and to see where are you standing. What are the policy, or what is the policy you are following in your institute about the mother-infant contact and feeding? Are you following a national policy or international policy? So I'm going to give you the vote, and it's going to be 20 seconds. And this is just a kick-off for our presentation. Can you start the vote, please? Can we share, after we finish, please, the result of the votes? Okay. So the majority of you have answered A, and some is B, which is the MOH A, and the CDC is B. Well, this is a good start. So the other vote, what are you doing in terms of separation of the mother and the baby at your institute right now? Is that based on the policy you have chosen, or according to the modified policy you have adopted? Can you start the vote? So it's going to be 20 seconds, and there is nothing right or wrong. We're just going to share with each other what are we in fact doing. So the majority, or 50%, answered A, which is no separation, but with the mother infection precautions, and some of you temporary separation till the mother is negative with a negative pressure room. Okay, so what we're going to do in the first half of this presentation, we're going to just follow the benefit risk ratio, and I'm going to start with the skin-to-skin contact. As you know, the kangaroo care, or the parents initiative, or the mother initiative program for the breastfeeding is quite important to be started as soon as possible in order to facilitate the breastfeeding, improve the thermoregulation, glucose control, and the attachment of bonding of the mother and infant, and improve the sleep pattern. If the risk need to be discussed, then you need to talk in brief about the mother has to take all the precautions, which include airborne and contact precautions, and to follow all of that if she want to take the risk. So everybody know that if that separation has happened, that might be an expense of the maternal milk supply, which is established during the first week of postpartum. And we know for the fact that the breastfeeding of no doubt has a lot of benefit, and especially for the respiratory tract infection for whatever the virus is. The mortality decreased by 14 folds, and what about not to mention the mother beneficial protection against many diseases such as cancers and diabetes type 2. So briefly, this is a Cochrane that was a long time ago, 2003, just to mention that the hospitalization from respiratory tract infection is dramatically decreased by the breastfeeding. And the longer the breastfeeding is, the more protection and the more lower respiratory tract infection. We don't know this yet for the COVID, but we know it for the majority of the virus. We know that immunoglobulin A is quite abundant in the breast milk, and it's more abundant in the breast milk in comparison to the serum, and it very rarely present in the formula. So we know from the evidence that a lot of viruses, immunoglobulin A is present, namely enterovirus, herpes simplex, HIV, and etc. So the presence of IgA in breast milk, as you might know, is one way that breastfeed protect against the infection and death. And the Ig antibodies have been detected, and it is recently published that it is detected for the mother who has previously infected with COVID. The strength, the durability have not yet been adequately studied in order to address the protection. So brief summary, the breast milk, we know now, the fact that we don't know before, the IgA is present and it is specific for the COVID, but the study is still not accumulating and not piled up yet. So the speculation behind this is breast milk might be considered as a preventive strategy to reduce the viral load for and subsequent development of COVID-19. Well, there is another, and this is the only Cochrane. It says Cochrane because it was done as a Cochrane method, but it only includes case report, case series, and family clusters. And 46 of the mother who been tested their milk, there was 43 negative. Only 3 of the 46 were tested positive in the milk, but no live virus was detected, only PCR DNA. So the only single child who was infected with COVID among the 3 who has the COVID, the virus PCR RNA was infected and was symptomatic, though we don't know because that study unfortunately did not mention the way of the feeding that the baby had, whether it is exclusive breastfeeding or no, or other mode of feeding. So this finding unfortunately neither confirmed nor refute the safety of the breastfeeding. So in summary, newborn can still, with that limited evidence, have the infection vertically from the breast milk till we get more studies. So the other survey question for now, what is the best initial feeding option would you think, or at your institute you are following in order to start the feeding? Number 1, direct breastfeeding, express breast milk, formula awaiting the more result, parents' wishes, so whatever they like, you're gonna do, donor milk if available. And believe me, donor milk, although it's not available here and it's not common, it's quite common in the Western world and in some also Muslim country as well. So I'll leave you with the votes. I'm gonna give you 20 seconds in order to share your response. Can you start, please? Okay, can we share, please? Okay. So as you can see, the D is only 1%. and A is 42, direct breastfeeding, and EBM 35. And this is what I expected, and this is what we're gonna find, and there is nothing right or wrong, as I said. So let me tell you, if we are separated, it's not only us, it's the major bodies of the people who are recommending the best way to feed are also separated and segregated. Everybody doing its own. So the bodies that don't favor the infant maternal separation, WHO, the UK Royal College of Obstetrics and Gynecologists, and a lot of European and Canada as well, they don't favor of the separation, and they do encourage the early breastfeeding. The one who favor temporary separation, the American Academy of Pediatrics, American College of Obstetrics and Gynecology, and the Chinese. Yes, the Chinese, they favor the separation, and they don't recommend the initial breastfeeding. So the one in between, actually, the Center of Disease Control, and also the Saudi Society of Maternal Fetal Medicine and the Saudi Neonatal Society, I'm going to show you in the next 2 slides. So the amazing things about our national guidelines, they go case by case, and they count, or they take in account the mother and the newborn wellness and sickness, and to some extent also they take the parent's decision and the parent-shared decision in order to make the decision. So the WHO, it was very fanatic and very rigid in terms of, listen, if you have a baby, regardless of the mother COVID, it's a human right for the baby, and he's gonna have the complete no isolation, kangaroo care with the breastfeeding regardless. Of course, with the precautions, airborne and contact precautions. So the WHO is, you might be, okay, you say, well, based on the rare of evidence of a virus transmission through the breast, I might go with the WHO, but let me tell you, it's a bit unclear for other centers. And the CDC, what I think stand is they go case by case, and they go considering the resources and considering the other evidence-based domain, which is the parent's decision or the parent values in order to determine what is best for them, as we're going to see. So what about the 2 national guidelines we have? This is an editorial that published in the Journal of Clinical Neonatology last March, and they clearly don't advocate like strict for the breastfeeding. They divide according to the mother and the newborn wellness. So if the mother and the newborn is unwell, they will make the recommendation, and I will advise you to read the recommendation. But if the mother is well and the baby is asymptomatic, they go by direct breastfeeding, and they will do the contact. And here, if the mother is unwell and the baby is asymptomatic, they will advise to discuss the feeding option with the parents, which 1% of us, they have mentions as one of the options. So again, they divide according to the maternal wellness, sickness, and the baby, whether they're gonna discuss or no. And in their recommendation, they said, based on the current and available data, breastfeeding benefits outweigh the potential risk of transmission through the virus through the milk. The Saudi Society of the Maternal, exactly in the same month, they published their own recommendations, and to some extent, it mimicked the CDC. And they says, you have to discuss this benefits and the risk and the dilemma that we don't have the clear answer, and to take a parent's shared decision. And they clearly mentioned that you have to consider the whole feeding 4 options, which I'm going to mention in the next few slides. So the last question, and sorry, before the last question, so what do we do now with this knowledge gap? So we left with uncertainty. So we're still not clear whether the virus transmits through the breast milk, because only 43 breast milk was studied. We know the beneficial effect of the breastfeeding and the kangaroo care, yet we cannot exclude the risk of the transmission. So how do we go from there? We need to take a based decision based on the evidence base. So the last vote for you today is, in order to make a decision, an evidence-based decision, everybody would hear, oh, we're gonna go by the evidence base. So what is the evidence base? So clinical expertise, parents' preference, best available evidence, healthcare resources, all of the above. And for the sake of the time, and I'm not gonna wait for the answer, but I'm gonna show you that David Sackett, who is the father of evidence-based medicine, and Hamilton McMaster, he clearly taught us that we usually, as a physician, tend to parent the people and tend to just go by either by the clinical expertise and the best evidence that is available. What about if it is not available? And we always forget the patient values and the way we counsel the parents. So to make it easy for you, this is the 4 domains of the evidence-based medicine, and we tend to use our parenting in order to guide the parents or the mother or the father in order to take the decision without considering other domains such as the clinical status, resources, patient value, and action and preference. And we don't consider the healthcare resources. So whatever is available for you might not available for others. You are private or not private, you have plenty of rooms, negative pressure or no. So in order to do the well-balanced discussion, this is, you need to discuss the 4 things: the risk-benefit ratio, the data limited so far, and you need to study, to tell them what is the available feeding options. We tend to say, well, we know better, direct breastfeeding with a strict application, it might be well. So ABM is the second option, and donor milk is actually one of the major feeding options that the countries with the breast bank, they are considering it and they are using it in the COVID pandemics. And the last thing, of course, is a formula as well. So regardless of the segregation issue or whether you want to start, if the mother like to breastfeed, you need to ask the mother to apply all the precautions as I mentioned before. So if the infant born to a confirmed mother, as you know, and is already said in the national guidelines, the baby need to be admitted till the mother is negative in NICU or negative pressure room. In NICU, if it's stable, unstable, and need invasive pressure ventilation. And then the healthcare provider should take all the precautions in order to prevent the infection. If the mother elect to ABM, express breast milk, the healthcare provider should take all the precautions because it is well known that the virus stays up to 72 hours in the plastic and it needs to be clean and to be dry up before you are using the milk for the baby. So we wrote a letter to the editor for the Journal of Clinical Neonatology stating that you have to, we advising that parents' decision should be taken in account before you said, well, the breast milk is the best and outweigh the benefit. The mother, they have the right to know what is the risk and what is the potential for transmission. Acta Pediatrica, we did a comprehensive different view in the conclusion, and it was quite political in order because the people, even in the reviewer, they divided between yes and no. But in conclusion, I have to share with you that it is suboptimal to err on side that, oh no, breast, we can exclude it, and you go to the other way, we need to give the formula, and the other way. So don't take a side. You need to, as I said, to take the whole 4 domains of the evidence base in order to make the shared decision as a clinical expertise. We tend as a healthcare provider to focus on what we believe is good, forgetting what is the value of the parents, what is the resources that you have, and what is the clinical status of the baby. So that should be taken into account. And I will conclude with this last summary, which said the same. So it is a trauma, it is a stressful time with fear and grief and uncertainty, yet this need to be conjoint decision with you, with the parents, and to take in consideration the health resources and the capacity that you have. Parents should appreciate that research is still in this field rapidly evolving, and most robust evidence will probably result in improved guidance in the near future. So at the end, if I left you with uncertainty, that doesn't necessarily mean it is the opposite of certainty. And my belief that certainty is an illusion. Think about it, how many times you think you are certain about something and it unfolds to be the other way. Embrace the openness rather than choosing upsides. And with that, I would like to thank you for giving me this opportunity. And I'll give you the next presentation for my next colleague.
Thank you very much, Dr. Rafat, for this comprehensive review of a very, very important subject. I have learned a lot from it. I think we have got a few minutes for one or two questions. Anybody has a question for Dr. Rafat? No? Okay. It's now my great pleasure to present my dear colleague, Dr. Tahani Jamali. Dr. Tahani is currently, we are lucky to have her as a consultant pediatric neurologist at the pediatric department of the IMC. She qualified at King Abdulaziz Medical School in Jeddah, and she did a long residency in pediatric neurology at King Fahd Medical City in Riyadh. Following that, she did a fellowship in epilepsy and EEG from King Faisal Specialist Hospital and Research Center. And she's going to talk to us on children with their first unprovoked seizure. Dr. Tahani.
Thank you, Dr. Naufal, for the introduction. Thank you for the organizers and the board committee and my colleagues and the participants. Thanks to all. I'm pleased today to share with you the topic of children with first unprovoked seizure, as many questions actually reach us in regards to treatment and evaluation for children with first unprovoked seizures. First, we define seizure as a transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And the unprovoked seizure, unknown etiology, as well as one that occurs in relation to pre-existing brain lesion or progressive nervous system disorder, often referred to as a remote symptomatic seizure. The unprovoked seizures are distinct from seizures due to acute conditions such as toxic, metabolic, fever, head trauma, or acute stroke, i.e. Acute symptomatic seizures. Epilepsy, defined as at least 2 unprovoked or reflex seizures occurring more than 24 hours apart, or 1 unprovoked seizure and the probability of further seizure similar to general occurrence risk after 2 unprovoked seizure, for example, more than 60%, occurring over next 10 years. This may be the case with remote structural lesions such as stroke, CNS infection, or certain types of traumatic brain injury, or a diagnosis of an epilepsy syndrome. Epilepsy incidence in population-based studies, incidence in childhood range from approximately 0.5 to 8 per 1,000 persons a year. An estimated 0.5 to 1% of children and adolescents will experience at least 1 afebrile seizure by age of adolescence. The highest incidence occurs at extremes of life. Etiology actually varies between structural, metabolic, genetic, immune, infectious, and unknown. Here are some examples of genetics causes where in neonatal period, as we can see, infancy. There are certain types of seizures during childhood, adolescent to adult, and familial epilepsy syndromes. For structural metabolic, any insult to cerebral cortex can cause a seizure. Seizures usually triggered by transient disruption of cortical neuronal functions such as disturbed metabolic state like high fever, hypocalcemia, etc. Temporary cortical disturbances after minor head trauma like a concussion, ischemia, chemical inflammatory excitation caused by infection like meningitis, sepsis, or encephalitis, or bleeding like intraparenchymal or subarachnoid hemorrhages. The other thing is neurodevelopmental lesions, where a disruption of one or more of three major steps in normal development of cerebral cortex. For example, proliferation of primitive stem cells, the neuroblast and germinal matrix, near wall of ventricles, migration of these immature neurons along radial glial fibers through the white matter to the developing cortex, and organization of the cortex. As we all know, there are different types of seizures categorized into focal, generalized onset, or unknown onset, and each has subcategories underneath it. It starts with assessment, and it starts with detailed history. As we know, the basic of each case is detailed history. The setting in which episode occur, behavior immediately prior to, during, and after the episode, physical description before, during, and after the episode, frequency, and duration. The important history of neurodevelopment for the child, past and current psychosocial history, including potential stressors, family history, medical history in possessing conditions, non-associated epilepsy like CNS infections or trauma, etc., prescription and illicit drugs. The other assessment is through detailed neurological exam, which includes neuropsychiatric assessment, general medical examination, and should include careful eye and skin exam. Assessment with EEG, or when it's recommended, it actually helps in providing support for the diagnosis, and it helps defining epilepsy syndromes and directs optimal therapy. Obtaining a tracing during awakened sleep, close proximity to the event also is important. Nonetheless, sensitivity and specificity is imperfect. When to do repeat EEG, if diagnosis is still in question after initial EEG, repeat tracing should be done. And one group found that initial EEG to be normal in 44% from 1 month to 16 years, with one or more newly diagnosed idiopathic or remote symptomatic seizures. And when repeated with sleep deprivation with initially normal EEG, interictal epileptiform discharges were found in about 35%, increasing the yield by 11%. Abnormal EEGs in healthy children also without seizures contain epileptiform activity. In one study, epileptiform discharges were noted in about 53 of 1,057, which is about 5% of normal school children aged from 6 to 12 years. Abnormal, in the second report, epileptiform abnormalities were found also in about 3.5%. In a follow-up studies over 8 to 9 years period, it showed that only 7 individuals subsequently developed epilepsy. Neuroimaging is recommended as initial imaging should be directed toward finding structural abnormalities, for example, neoplastic, malformative, vascular, traumatic, and others. Of course, brain MRI has superior sensitivity, detecting lesions, and lab testing uncover medical etiology. Initial screening with metabolic test panels may be indicated in some cases. And targeted genetic testing has variable clinical utility depending on clinical and genetic heterogeneity of particular syndromes, and broader genetic screening in children with epilepsy of unknown cause. Treatment. There was no clear evidence-based guidelines have emerged regarding initiation of treatment after first unprovoked seizure in pediatric population. As for that, there has been many questions raised by the American Academy of Neurology to individualize the treatment for children with first unprovoked seizure. first question was, what are the potential risks resulting from having a second seizure? And they found that each attack facilitates occurrence of another by increasing instability of nerve elements, like kindling in animal studies. And in animal models has prolonged or recurrent seizures under certain circumstances cause neuronal injury and predispose to epilepsy. The seizures may alter neuronal activity and circuitry. The relevance of data from these animal models to seizures in humans is unclear, and data from children indicate that even prolonged seizure rarely cause clinically discernible brain damage unless associated with an underlying acute neurological insult. One reason treatment may be considered, concern about risks of physical injury or death from subsequent seizure, and we have to have in mind that serious injury from seizure in a child is a rare event. The other thing is the SUDEP, which called the sudden unexpected death in children with epilepsy, which is very uncommon. When death occurs in children, it's nearly always related to the underlying neurological handicap rather than epilepsy. And risk of death in childhood onset epilepsy is same as that of general population for children without significant handicap. No studies were found that examined whether treating a child after a first unprovoked seizure would reduce the risk of either subsequent significant injury or sudden death. The other question was, how likely is a second seizure? There were large studies and cumulative risk of recurrence increases over time. However, in some others, majority of recurrences occur early in first first 2 years. At any given time, reported risk recurrence is highly variable. At 1 year, it varies between 14% up to around 65%. Other question was raised, how likely are multiple recurrences in children with who present with a first unprovoked seizure? So a minority of children experience many recurrences. In one study enrolled around 200 children with follow-up for 2 years, the recurrence rate was about 50%. And another study enrolled about 400 children with follow-up for 10 years, 46% had one or more recurrences. Over the extended follow-up period, 19% of the children enrolled experienced at least more or equal to 4 seizures, and only 10% experienced more or equal to 10 seizures. Other question was raised are there factors that increase the recurrence risk? They actually found that the underlying etiology carries a recurrence risk. For example, idiopathic cryptogenic, about 30 to 50%, and in remote symptomatic 50%. EEG also being abnormal had carried also some percentage, and remote symptomatic etiology like severe trauma and children with cerebral palsy also carried risk. Are there special considerations if the first seizure is prolonged? In about 10 to 12% with a first unprovoked seizure more than 30 minutes, and morbidity and mortality of status epilepticus in children relatively low in absence of acute progressive brain injury or disease. Overall recurrence risk following prolonged first seizure was no different from recurrence risk following brief first seizure. However, if a child with initial prolonged seizure did experience a seizure recurrence, is more likely to be prolonged. How effective is treatment after first seizure in prevention of recurrences? Treatment with anti-epileptic drugs after first seizure reduces risk of seizure recurrence. The magnitude of impact is variable, and the evidence from pediatric studies alone is not sufficient. Does treatment with anti-epileptic drugs after first seizure change long-term prognosis for seizure remission? There were actually 2 class 2 studies provide no evidence of a difference when treatment is started after first seizure versus after a second seizure in achieving a 1 or 2 year seizure remission. What are the nature and frequency of side effects of anti-epileptic drugs commonly used after first seizure in children? There were actually many, as we know, like systemic side effects, rashes, hirsutism, weight gain, severe reactions, for example, hepatic or bone marrow toxicity, and severe Stevens-Johnson syndrome, effects on behavior and higher cortical function, teratogenicity in teenage girls who may become pregnant. So in conclusion, about 1% or approximate 1% of children and adolescents in the USA will experience at least one unprovoked seizure by age of 14 years. Majority of children who experience a first unprovoked seizure will have few or no recurrences. Only approximately 10% will go on to have many, more than or equal to 10 seizures regardless of therapy and treatment with antiepileptic drugs after a first seizure as opposed to after a second seizure has not been shown to improve prognosis for long-term seizure remission. Treatment has been shown in several studies combining both children and adults to reduce the risk of seizure recurrence. There is a relative paucity of data from studies involving only children after first seizure. Antiepileptic drugs therapy in children who have epilepsy has potential serious pharmacologic and psychosocial side effects. No separate data exists, especially for treatment side effects in children who have experienced only a single seizure. There is no evidence about whether treatment, specifically after first seizure, alters risk of SODIP in children. As for that, it was recommended that decision as to whether or not treat following first unprovoked seizure must be based on risk-benefit assessment that weighs risk of another seizure recurrence against risk of chronic antiepileptic drug therapy. Decision must be individualized and take into account both medical issues, patient and family preference. Therefore, the following recommendations are made for children and adolescents with first unprovoked seizure. Treatment with antiepileptic drug is not indicated for the prevention of the development of epilepsy, and treatment with antiepileptic drug may be considered in circumstances where benefits of reducing risk of a second seizure outweigh risks of pharmacologic and psychosocial side effects. Thank you.
Thank you very much, Dr. Tahani, for this comprehensive review of the literature and answering some specific questions that occur to every pediatrician's mind. I'm already having reports from the audience that this was an excellent lecture and they have learned a lot. Can I ask people if they have got questions for Dr. Tahani? No? Okay, we will repeat this session at the end, i.e. ask people whether they have questions to any of our three excellent presentations. Thank you very much, Dr. Tahani.
Thank you.
Now, it's my pleasure again to introduce one of our new colleagues, Dr. Ala. And Dr. Ala is our consultant pediatric gastroenterologist, and we are very lucky to have her. She is board certified in pediatrics, and she has done a fellowship in pediatric gastroenterology, hepatology, and nutrition. And she is going to talk to us about something we see on a daily basis as in our general pediatric clinic, and that is constipation. And she wants us to quarantine constipation. Dr. Ala.
Thank you so much, Dr. Nofa, for the introduction. I would like to thank the board committee and the organizers, all my colleagues, for this opportunity to be a speaker in tonight's pediatric club. I will be speaking about quarantine constipation as part of functional constipation. I have to share this. Okay. So functional constipation prevalence is almost 30% worldwide. It is a bothersome symptom that negatively affects the quality of life in patients and their families and contribute to increased healthcare utilization and associated costs. We diagnose functional constipation based on around 4 criteria, which constitute a 1 month of at least Yes?
Share screen.
Can you hear me?
Share screen.
It's not shared? How about now?
Yes, okay.
Am I still on?
Yes, yes.
You're fine.
Okay. So I was talking about the ROM 4 criteria to diagnose functional constipation. It constitutes 1 month of at least 2 of the following: 2 or fewer bowel movement per week, or history of excessive stool retention, painful or hard bowel movements, large diameter stool, large fecal mass in the rectum. These for children younger than 4 years. In toilet-trained children who are above 4 years, two additional criteria were added: at least 1 episode of incontinence per week, and a history of a large diameter stool that obstructs the toilet, of course in the context that there is no other medical condition after appropriate evaluation. I will highlight some important definitions. Soiling is the involuntary passage of small amount of stool resulting in staining the underwear. Encopresis is the repeated voluntary or involuntary passage of normal stool into inappropriate places like clothes and floor after the age of 4. The term fecal incontinence actually encompasses both encopreasing and soiling, and it is defined as defecation into places inappropriate to the social context at least once per month for a minimum period of 2 months. Intractable constipation is the constipation that does not respond to optimal conventional treatment for at least 3 months. Fecal impaction is defined by physical examination as a hard mass in the lower abdomen, and by rectal examination as a dilated rectum filled with large amount of stools, and on the plain abdominal radiograph as excessive stool in the distal column. I would like to share with you a case that I saw in my clinic. She's a 4-year-old girl, Egyptian, medically free. She complains of constipation that started during the lockdown time. She was previously healthy with no issues in regard to her bowel motions. She described her stool as very hard, lumpy, painful defecation with the frequency of every 5th day, together with daily appearance of soiling and on and off incontinence. No abdominal pain was described, no bloody stool, no decrease in appetite or weight, no vomiting, and other systemic review was unremarkable. Since the lockdown, her eating habits were changed. Her diet mainly consisted of candies, chocolate, and chips, which were given by the parents just to ease her staying at home. Her consumption of fiber diet, as a result, was markedly decreased. Her sleeping habits were disturbed. She would stay up all night with the parents and will sleep in the daytime mainly. On examination, her abdomen was distended with normal skin appearance. It was soft and resonant to percussion with a normal bowel sounds, no organomegaly. Rectal exam revealed a small fissure at 6 o'clock, non-bleeding, so digital rectal exam was not done at that time. Started on disimpaction therapy for 3 days of fleet enema, followed by Movicol as maintenance, and I gave her a follow-up appointment for reassessment in 1 to 2 weeks. In her first visit to my clinic, after 3 weeks, she was not improving. She only had received the fleet enema for 3 days and passed large amount of form stool as per family, but she totally refused to take Movicol. She did not tolerate the taste. She was still having similar frequency of passing motion every 5th day. However, she was alternating now between softer stools and harder stools with more frequent incontinence. No modification of diet or sleep were done by the parents. Upon more questioning of psychosocial aspect, she was very upset and wants to travel to meet her friends and family like each summer she goes to her country. And the mother mentioned that she would pass her bowel motion and urine on her clothes and would refuse totally to be seated on the toilet, even though she was completely trained before this episode. On examination, she was well interactive. Her abdomen was still distended, soft. Rectal exam showed healed fissure, so digital rectal examination at that time yielded hard stool felt in the rectum. At this point, I sent for celiac screening and thyroid function, and all became normal. And as a treatment, given course of 3 days disimpaction with fleet enema, followed by lactulose this time for maintenance. Also, they were instructed to maintain good dietary habits with water intake, toilet training, and table-to-toilet regime. On her second and third visits, which were 1 week apart, she was compliant on the maintenance lactulose. However, she was still having same symptoms. The dietary issues still were there, sleeping disturbance. She was very upset. She's not going out. So the family started to go out more, take her for a walk, shopping. Her fecal incontinence at that time improved. Parents were worried and frustrated as she still was not happy and satisfied. She doesn't want to pass stool in the toilet. So abdominal X-ray was ordered at that time. As you can see from the picture, her X-ray showed loaded colon with feces. The right colon, left colon, and rectum all are fecally impacted. Her examination showed still distended soft abdomen, and as a treatment with this finding, I started her on bezetocodile, which is a stimulant laxative, the course for 5 days, and was continued as lactulose as maintenance. On her fourth visit, 1 week after, the mom reported the effect of bezetocodile taking effect after the second day. She passed large amount of stool. She continued to have softer motion and significant less episode with improved frequency of stooling. They have made dietary changes and regulation of her sleeping. She was going more outdoor and she was happier. Her abdomen, even distension, was improved. And she continued on lactulose as maintenance therapy, and of course with reinforcement of diet and sleep with psychosocial aspect. So what is quarantine constipation? Actually, in this era of COVID-19, the coronavirus has changed our lives. The lockdown made us work from home. The children are being schooled at home with online education. They are staying indoors, whether because of the curfew hours or because of the fear of socializing and mixing up with people. These changes affected sleep, diet, and for some, the toilet habits, which have given rise to the term quarantine constipation. So why does quarantine constipation happen? The problem begins with the circadian rhythm, which is the natural process in the brain that regulates the sleep-wake cycle. Colon has its own circadian rhythmicity, and any disruption will lead to dysmotility or decrease the mobility of the colon. So I will be briefly talking about circadian rhythm and the gut. What is circadian rhythm? It describes the endogenous generated rhythm that occurs approximately every 24 hours. It has a relation to the light and dark circle because of the rotation of the Earth. It plays a fundamental role in the survival, ensuring the organism's internal physiology and external environment synchronization. The master circadian pacemaker is located in the hypothalamus. However, tissues and organs harbor self-sustained cellular circadian rhythmicity. This includes the GI tract. There is evidence that this circadian rhythms in the peristalsis of the digestive tube, so any disruption will lead to the impaction on the motility. For example, the colonic motor activity is minimal during sleep time. The GI tract is the most important source of melatonin and serotonin outside the CNS. Both neurotransmitters play an important role in the GI motility and, of course, in the circadian rhythmicity. The GI ecosystem has a diurnal variation according to the state of food and fasting throughout the day. A change in the diet can rapidly shift the composition of the gut microbiome and in turn is responsible for the reprogramming of the circadian rhythmicity. Studies showed that lifestyle factors like sleeping at daytime, working night shifts have higher prevalences of IBS, hence the functional bowel disorders, and sleep disturbance is associated with fewer meals and more snacking. In this slide is sum up that the external environmental factors like the eating late and sleeping late, light during the night or during sleep will affect the internal clocks centrally and peripherally. This will affect the normal functions of the digestive system that leads to pathologies like IBS, inflammatory bowel disease, and also cancers. So I will be talking now about lockdown and stress, the possible links. The pandemic, of course, made us more anxious and more stressed. In a cohort study that was done in 2010 on Sri Lankan children, stressful events were associated with constipation in children, included separation from best friends, loss of a job by a parent, and severe illnesses in a family member. During lockdown, children are usually exposed to at least one of these stressors. So how stress affects the gut? Psychological stress can cause GI symptoms like nausea, vomiting, abdominal pain, and an alteration in bowel habits, whether diarrhea or constipation. It is mainly by the stress-induced corticotrophin releasing factor that affects directly the intestine. And of course, there is recent evidence that it also affects the microbiota. So this also leads to this motility. So going back to our patient, she had a disturbed sleep schedule, eating habits were changed, and she was also stressed due to being indoors away from family and friends in her country. So how does constipation present in a clinic? The patient would have infrequent hard stool, painful defecation, passage of small amount of bright red blood if there is a fissure, abdominal pain and cramps, distension, decreased appetite and early satiety, irritability, soiling, and encopresis. Some of the symptoms may disappear immediately after passage of a large motion, like the abdominal distension and the irritability. This is called a Bristol stool chart. It is very helpful in the clinic. We show the parents and the child how, and it gives them a chance to know what is the description of their bowel habits or stooling. The normal is type 4, 1 to 3 could be constipation, and 5 to 7 is more loose motions. In this picture, it shows the chronic constipation effect with fecal impaction in the rectum, leading to dilatation. The more stool will be formed and backs up in the colon, will be impacted elsewhere other than the rectum. The softer stool will come and find its way through the impacted stool and would come as a soiling, encopresis, or even in fecal incontinence. It's worth to mention the normal stool pattern in infants. It's 2 to 4 per day. Breastfed infants can have 1 to 2 motions per week because of the complete absorption of milk. Toddlers have 1 motion per day, and older children average of 3 to 5 per week. What is the vicious cycle of events in functional constipation? The child has hard, painful stool. He doesn't want to repeat the experience. He will retain stool. Retained stool will be hard because the colon will keep absorbing water. The colon will be dilated. This will lead to decreased sensation for sensory input and output. The child continues to have hard, painful stools, and this cycle repeats itself. So what contributes to this? Difficult toilet training, stressful event, illnesses, and withholding behaviors, like because the child wants to play, and availability of toilets. The parents could mention withholding behaviors like tiptoeing, rocking back and forth, stiffening buttock and legs, sitting on the edge of a seat, hiding in a corner with unusual postures. This slide highlights the alarm signs and symptoms that we need to be careful taking history and examination during interviewing the patient. Examples: constipation starting extremely early in life, below 1 month, passage of meconium is delayed beyond 2 days, failure to thrive, fever, bilious vomiting, abnormal CNS examination of the lower limb, tuft of hair on the spine, and extreme fear during anal inspection. Other causes of constipation, we have non-organic and organic. Developmentally, like CP, depression, constitutional, reduced stool volume like underfeeding. Organic causes include anatomical malformation, metabolic like hypothyroidism, neuropathic, abnormal abdominal musculature like gastrochiasis, connective tissue disease like Ehlers-Danlos, drugs like opiates, and other like cow's milk protein allergies. According to the evidence-based recommendation, lab tests are not recommended for any functional constipation. However, if the child is not responding to treatment or any flag signs, red flag signs in the examination or in history, we send some labs. For example, celiac screening, hypothyroidism, workup, and hypercalcemia can cause constipation. In regards to imaging, it is not recommended for the diagnosis of functional constipation. There are many described radiographical scoring systems like Bar, Leach, and Blethen, but they are not routinely used. They all rely on being the clinical criteria, and they have variable sensitivities and specificities. So why some patients undergo imaging? If the patient is presented to ER with acute abdominal pain as a chief complaint, presenting with frequent stool and overflow diarrhea, patient does not want to go through rectal examination. Doubters, like the parents, are convinced the child has no constipation, he's passing motion every day, not seeing improvement, reinforcing bleeding, and we need to be objective sometime with the family. So going back to our patient, the radiograph were ordered as she was not improving after 4 weeks of therapy, and parents were frustrated and started to doubt the diagnosis. In regards to management, it's by the evidence-based recommendation from the European and the North American Society of the Pediatric Gastroenterology, Hepatology, and Nutrition. We have non-pharmacological and pharmacological. Based on expert opinion, the recommendation were to be having normal fiber intake, normal fluid intake, normal physical activity, and explanation and guidance for toilet training in a child who is 4 years or above. And they did not recommend, of course, alternative treatment like acupuncture or hypnosis. It's worth to mention the daily recommended intake of fiber. This table shows the normal intake of fiber per day. We can see that since the age of 9, they recommend there is a change between the boys and the girls. Boys need more fibers in their diets. These are few examples, and surprisingly, 1 cup of popcorn gives 1 gram of fiber. Too much fiber, however, can cause uncomfortable side effects like bloating and gas. Other than the diet, we stress on physical activity, on table to toilet regime, which retrains the bowel by using gastrocolic reflex. We tell the parents, seat the child in a toilet after 10 to 15 minutes from a meal. We advise them for not to punish the child because this aggravates the problem. Star charts can work, and age-appropriate discussion might be initiated. Tips for parents on toilet training: we tell them to start when the child is ready and ensure a calm, comfortable environment and not to be rushed. For the pharmacological treatment, we have disimpaction and maintenance. The disimpaction by polyethylene glycol or enemas are equally effective. Of course, the doses differ, and the course of the disimpaction is between 3 to 6 days. For the maintenance therapy, the first line treatment is polyethylene glycol with or without electrolytes. As a second line, if the patient is not tolerating the taste like our patient or not available, we can start lactulose. Others like mineral oil and stimulant laxative can be used as second line treatment. It is important to continue therapy at least 2 months and to start to discontinue if there is 1 month at least of improved total symptoms. Treatment is gradual. And it is important that if the child in the toilet training developmental age, the medication should be continued and not stop until he achieved or she achieved the toilet training. Timing of the medication to be administered first thing in the morning is better for the child and would most likely pass stool when they come home. And we need to tell the family that there will be most likely diarrhea, so do not stop the treatment until this impaction is achieved. This table shows some of the oral and rectal laxatives. Rectal laxatives are not recommended in children. The oral laxatives, we have fecal softener and stimulant. Just to mention, stimulant laxatives are not to be used more than 30 days. Thank you so much.
Thank you very much, Dr. Ala, for an excellent lecture on constipation, something that we really need to reinforce and both remind ourselves and our juniors about the importance of this common problem. Do we have any questions for Dr. Ala?
دكتور نوفل السلام عليكم.
Yes. وعليكم السلام ورحمة الله.
دكتور عبد العزيز التويم معك. جزاكم الله خير.
أهلا أستاذ. أهلا أستاذ الكريم.
الله يسلمك. بالنسبة للأسئلة فيه question and answer column حتجدوا على فوق على اليمين مكتوب Q&A. There is maybe some question, you'll find it in there.
Yes.
About so maybe if you want to leave it till the end or if you want to go now, it's up to the moderator.
Yes, we have now finished more or less. We have had our 3 presentations. If you want, we can go to the questions. I've got
because they cannot go in the microphone. Most of the audience, they can write only their questions. they probably unable, except the panelists. The panelists, they can ask, but so it's up to you if you want to leave it till the end or if you want to go now.
Yes, I wasn't aware of that. Let's go to the questions, my friends.
You'll find it on the Q&A.
Yes, I found it. Now, I've got a question from Dr. Tasneem Al-Taib, and she says, can we get handouts, please? Yeah, so we can ask our speakers whether they could send handouts to the attendee. Question 2 by Nadeem Hashmat Ali. Drug of choice for first unprovoked seizure if we plan to start. So I think he means if we decide to start our first start treatment after the first seizure, unprovoked seizure, which is not recommended, as Dr. Tahani was saying, what shall we start? Dr. Tahani.
Thank you, Doctor. It actually depends on many factors. It depends on the age of the patient. It depends on the type of the seizure. It depends on many factors, EEG result, if there are any abnormal interictal epileptiform discharges or seizures recorded in the EEG. And it depends on the underlying type of seizure. So it has many factors actually to start this question on the drug of choice for each patient. It needs to be individualized.
Thank you. I've got a question here from Dr. Duha, and she says, if children are infected with the virus, it may infect second time. I think she means if children caught COVID-19, are they liable to have it again? Dr. Rafa, do you want to answer that?
Well, if she meant she get it from the breast milk or from somewhere else, this is a difficult question to answer. And from my detailed reading and attending many of COVID webinar, actually we don't know this.
Okay, so it's still unclear.
Yes.
Another question from Dr. Habullah to Dr. Tahani. Are there any cognitive drawbacks of recurrent seizures?
Actually, this needs another topic to be discussed for the recurrent seizures. It depends also on the effects of cells from a seizure or from the duration that seizure occur in.
Thank you. Another question from Dr. Dania. Do we have to do an MRI in a child with epilepsy with signs of neurological disease?
As we mentioned, it's part of the assessment for children with seizures. For example, it depends also on the type of seizures. And there are also some recommendations for doing neuroimaging actually for seizures. But to identify the underlying etiology, whether it's structural, vascular, it helps actually in identifying what is the cause for this seizure to occur.
is that supposed to be after the first seizure or later on after recurrent seizures?
It depends, Dr. Naufal, because in focal seizures, for example, we need to do brain MRI to identify whether there is something in this particular area causing this seizure, especially for focal seizures. There has been many talks about that, for example, for absence epilepsy and for generalized epilepsies, whether to do or not to do.
Okay. Another question from Dr. Wala. She says, in the ER, do we have to keep the child for observation or to admit him the hospital? And do we have to do imaging?
Actually, this is an individualized also question because some children will only experience one seizure that is brief, not defined as status epilepticus, and they come to the clinic for the further workup. But it needs further actually questions to answer and individualized actually approach.
Can I, Dr. Naufal?
No.
Dr. Abdulaziz Tuim again. If I can comment just on Dr. Tahani, you know, the parents, when their child get a seizure, they get frightened and it's very serious for them. And, you know, while you are trying to investigate what's the cause of the seizure and the risk of having another seizure is still there, I think it will be more safe to admit the child at least for observation for 24 hours. Of course, you know, if you have a bed or it's available. What do you think, Dr. Thani?
Yes, actually, we do this approach in our hospital. It depends on the availability of beds and the status of the child. If the child was actually had the seizure already and back to baseline, normal baseline, parents, they came for evaluation, basic investigations, workup to be done in the ER. And then at least for the common causes for seizures, at least treatable causes as well. And then after stabilizing and preferring to do further investigations, if it's advised for this child, then we go from there. Either we admit the patient or they come to the clinic. But yes, we do this approach of admitting the patients for 24 hours for subsequent recurrent seizures. And we have, alhamdulillah, in our hospital, the chance or advantage of doing EEG and brain MRI within the first 24 hours of having the seizure. So we do the full workup for the patient once they are admitted to the hospital. And then we could speak to the parents, reassure them, and explain in a detailed, let's say, talk with them. And they have their answers. And then we have also a follow-up clinic that is nearby just to approximate the, and to catch if there is any recurrence, as we said, the kindling model for having a second seizure.
Thank you.
I just have to add, sorry, Dr. Abdulaziz, تفضل.
No, it's okay. Thank you very much. Thank you.
Okay. I just want to add that in the UK, we had a rule that first seizure in children, the child has to be admitted. Okay. Follow-up, i.e. further seizures, the admission is individualized. So recurrent febrile seizures, they don't need to be admitted. And otherwise, we individualize if the patient needs admission. Okay. Another question for you, Dr. Tahani. Seems people are bombarding you with the questions. Question from Dr. Nadeem. What is the role of anti-epileptic medication in complex febrile seizures?
Oh, febrile seizures is actually another topic. It's a big topic.
Another talk.
Yes. With its subcategories, the complex and the simple type of febrile seizures. It has another approach actually. It's not like the first unprovoked seizure, because this is defined as a provoked seizure with fever.
Okay, so maybe we invite Dr. Tahani again to talk to us about febrile convulsions and the types of febrile convulsions and the recurrence risk and all that. It is a very large topic, very important topic, something we meet every time we are on call. Okay, now we have a question for Dr. Rafat from Dr. Hala. What do you do in your hospital if the mother has COVID-19?
Actually, I was looking forward for this question. Let me tell you, we had our guidelines change 3 times since the beginning of the pandemic. The first month of the pandemic, we strictly prohibited any breastfeeding because we don't know. And the data was contradicting, as you have seen from the WHO, CDC, the Canadian, the American. And just few weeks after, when we get more studies, we review and we revise, because we have, in my center, we have actually 3 fanatic people about the breastfeeding. So I had to sit with my team, which is the breastfeeding consultants, and a few of them, they are attending the presentation today. And we have to address our resources, as I showed you in the evidence-based model for making the decision. So for the ladies who was suspected with the COVID or confirmed with COVID, we did the protocol for the screen, as you might have guessed. And later on, we adopted the WHO in terms of sharing the room, because in our unit, we have a big room, and we dedicated one of the floor for the COVID team, and also with the COVID mother and the babies. We encourage the express breast milk, and these are the second phase. So it wasn't still conclusive for the team and the COVID team. And the third phase, as I might have already showed you in the presentation from the active pediatrica, we adopted the combination of the CDC, the WHO, and the other consensus, including the Chinese. So again, I mean, we adopted the decision process in terms of taking the 4 domains of the evidence-based, mainly because we have a good resources in terms of the human power, and also because of the room, and because of the team of the breastfeeding consultant and the breastfeeding advisor. And actually 2 of my team, neonatology specialists, they are also breastfeeding counselors. So they helped me a lot. So what I advise you is don't take a side, okay? Do your own policy and guidelines according to your setting, according to your resources, according to the power, the human power you have. And there is nothing right or wrong, as long as you talk to the parents and before the delivery, if you are lucky enough to see them, in order to discuss the contact, if you are lucky and have a good room and space. And then if you are not that lucky, you might also discuss afterward. And based on that decision, and based on the guidelines you have proposed to them, you might take that decision. So the bottom line, shared decision is the way to go. Thank you.
Thank you, Dr. Rafat. Coming back to Dr. Tahani again, a question from an anonymous attendee says, regarding generalized seizures that resolve with diazepam, and then the patient develops focalization of seizures. What may be the possible explanation?
What I can think of is that it could be started with focal seizure, but it was not witnessed for the first seizure, and then it was focalized. This is for if the question was about the recurrent seizures. But then if the question was regarding the same seizure, it has many answers regarding where it actually goes to eventually for the seizure itself. It can start with generalization, it goes into to be focal later. It has many advantages of localization actually, and we put a weight on it to identify the localization of seizure where it started in the brain. Sometimes even after the seizure we have lateralization also signs, and we depend on it in terms of localizing the seizure onset.
Thank you. Okay. Another question from Dr. Ahmed. The question is a bit generalized. What are the psychiatric effects of lockdown on children involving all body systems? Any takers?
I think he means that the psychiatric effect of lockdown involves all the body system. In my presentation, I just mentioned the effect of it with the gut. But I think it's a generalized comment, to be honest.
Okay. Anybody else would like to add a comment? Okay. A compliment from Dr. Thamer. He says, thanks for your great job. I gather he means everybody. And a question for Dr. Ala. What about healing creams for anal fissures?
We don't actually use healing creams for anal fissures in pediatrics. We just treat them with softening the stool.
Okay.
Can I comment?
Indeed.
Dr. Ala, thank you very much. Abdulaziz Twem, and I am very happy to see all our colleagues and our friends, in this meeting. But sometimes when you're dealing with children with chronic constipation and anal fissure, it is very painful for those children when they go to, to the bathroom or start defecation. So it's a common practice among pediatricians to prescribe xylocaine gel to be on the fissure just like half an hour before the defecation. So you think this is not a good practice, because otherwise those children, they will keep crying and protect themselves not to go to the bathroom, and constipation get worse. So applying like xylocaine 2%, do you think this is a good idea or not?
Actually, personally, I don't use that. The main issue now to to overcome this problem is to, for example, we give the xylocaine, but the stool is still hard. It will never heal. So the main therapy is to have the softer bowel motions. Sometimes we instruct the parents just to apply any Vaseline or petroleum jelly to the area externally just before defecation, just to ease the process. But xylocaine, actually, the parents might be using it wrongly. And for the healing creams that are available in the pharmacies, actually, we had a patient that had a prescription from a pharmacy to use the adult medication, and she used it wrongly. And this led to toxic effect, and the patient was in ER with cerebellar problems. So that's why we don't really recommend these kind of therapies to pediatrics.
I have a comment.
اتفضل Prof.
I would like to thank Dr. Ala for this extensive review of constipation. لكن في الحقيقة for anal fissures, as Dr. Abdulaziz mentioned, these children are usually having severe pain, and sometimes they are unable even to sleep or even to pass a stool. As Dr. Ala mentioned, we always use emollient like Vaseline, and we ask the mother always to put the Vaseline plus water bath. And this, we advise the mother to keep the child in a water bath for 3 or 4 times a day, 10 minutes each. And this will also relieve the pain. For the xylocaine, I don't think is available now, but there is lidocaine, which is available. And of course, sometime I advise parents to use it just to relieve pain. But others who don't use it, as Dr. Ala mentioned. Thank you very much.
Dr. Ala, another question for you from Dr. Muhammad Al-Goshimi. He says, thank you, Dr. Ala. Is PEG with electrolytes safe in children? Maybe before you answer that, Dr. Ala, you can tell us, is there PEG with or without electrolytes?
Yes, we have both types, and we both are safe in children, given that the child have no comorbidity, and he's a healthy child, he has no renal issues, and he has no comorbidities. We can use both, with or without, and it's safe, really.
So tell me more about PEG with or without. I thought we use Movicol.
Yes, which contains magnesium, yeah. So some of the polyethylene glycols, they usually they contain like magnesium, sodium, and these are with the electrolytes. There are many types of in abroad. We have only I'm familiar with Movicol in our country, really.
So there are types without electrolytes abroad.
Yes.
Oh, I haven't come across them at all. Okay.
Yes, the one we use here is Movicol. Yeah, this is what I'm familiar with in our country.
Movicol has electrolytes.
Yes.
Yes. Thank you, Dr. Ala. Dr. Tahani, there is a question here which is not very clear. It's from Dr. Ziad Al-Tamimi.
Yes, I noticed it was not clear, Doctor, because it didn't define in which case or which type of.
Absolutely. Absolutely. So maybe we'll ask Dr. Ziad to rephrase the question.
Yes.
A question from Dr. Ahmed to Dr. Ala. When do we send the child with constipation to a surgeon?
If there is any red flags, like the patient is not passing stool unless there is stimulation, if the constipation occurred very early in life, if there is delayed meconium passage beyond 48 hours, if during examination the bowel is the abdomen is distended, and during digital rectal examination there is a gush of stool after the exam, these are signs that could be surgical. So we usually take their opinion with us. Or if the patient is not responding totally to the conventional therapies.
I just tell you about a child I saw when I was a registrar at Charing Cross Hospital in London. You know, the child comes in and every time he sees a different registrar. So mom came and said, look, I've seen so many registrars like you, and I really need you to do something. Nothing is working, okay? And to me, it sounds like ordinary functional constipation. And I gave in to the mother request and sent the child to a surgeon. And to my surprise, it was Hirschsprung disease. So it is really quite difficult. It's not easy.
Yeah, it's tricky. Yes, I agree. Especially in those cases with ultra short segment Hirschsprung disease that could present later in life. I actually saw some adults presenting with this very late, I mean, in their 30s.
Yes. Another question for Dr. Tahani. He says, Dr. Hala, she says, your experience not to treat the first attack of seizures, even if there are EEG changes.
As we mentioned, it depends and needs to be individualized. For example, if the patient actually has an underlying child with cerebral palsy or another disease that is there or something, it depends.
Yes, especially that normal children could have
EEG changes, as we mentioned, yes.
So I always tell moms, if you go to the center of Jeddah and pick 100 children, 5 or 10, even 10% people say have EEG changes.
And there is, it's not a rule, but there is a saying that says we treat patients, we don't treat EEGs, except in certain types, actually, or in certain circumstances, as it's well known, of course. So we go clinically and we have the EEG as a support tool.
That's a very good saying. We treat the patient, not the EEG. Dr. Ala, Dr. Hala is asking you, can we use probiotic for treatment of constipation?
Actually, there isn't a sufficient evidence currently to be used. Studies are ongoing to see the effect of prebiotic or probiotic in the treatment of constipation.
Okay. Another question.
I have a comment on prebiotic.
Indeed.
Unfortunately, prebiotic is abused to treat children with different abdominal complaints, either with abdominal pain or constipation or diarrhea or. I think there is no study to support its use except in the neonatal necrotizing enterocolitis. Others, just it is, I think, media from pharmacy and just giving medication unnecessarily, maybe in future, but no study to support it is used. All is controversial. Thank you very much.
Thank you.
Maybe we can ask Professor Asiri to open his camera, maybe. Can we do that? Go ahead, Dr. Naufal.
Professor Asiri, can you open your camera, please?
Yeah. Go ahead.
Another question for Dr. Ala. What about the treatment of chronic constipation in a child with CP?
Actually, this is another topic. It's a big topic, and there is a published guidelines in the treatment of different GI problems in neurologically impaired children. It was published in 2017 in the Journal of Pediatric Gastroenterology, Hepatology, and Nutrition. So we can, if the person is interested, they can view it.
Okay, so a question for Dr. Tahani. What are the admission criteria for a child with his first unprovoked seizure?
So as we mentioned, the emergency department assessment is going to be very informative. For example, if the child is delayed or abnormal neurological exam findings, if the seizure is prolonged, defined as one of the definitions for status epilepticus, for example, all these things in matter of admission for the child. And also, as Doctor mentioned, also parents' concern, one of the outways for admitting the child. Of course,
So-
most of the workup and stabilization will be done in ER. So the admission will be for observation and for further workup for the
So
patient.
is it your advice to admit most children or all children with?
We do mostly, yes, to admit most patients with first unprovoked seizure, especially because they are not on antiepileptic drugs, which is withdraw for letting patients back to their homes. But we have always the advantages of having home rescue medications, for example, rectal diazepam or bacalmidaz. Midazolam. So this is one thing to be considered, with also explaining to the parents what to expect for seizures and what to do in cases of rescue for patients with seizures.
Yes. So as you say, it's also very important for education of parents.
Yes, of course, being also not having a nearby emergency department, not for example, in areas where there are no hospitals or not nearby an emergency department that deals with seizures. Sometimes we encounter that. And we advise patients, parents always to look for a nearby hospital, but we mostly admit patients with first unprovoked seizures for workup. And we do it mostly within 24 hours, and we observe them and we do the work. Alhamdulillah, the facilities are there to do this.
Dr. Farhan is asking you, Dr. Tahani, if you have a child with unprovoked seizures, but otherwise healthy, should they undergo imaging and or EEG?
I think we have answered this question, another question that was changedly reframed, but we have answered that we do the EEG and we do the neuroimaging in order to look for the underlying cause.
Thank you. Dr. Ala, Dr. Muhammad is Muzaffar asking you, how do you treat neonatal constipation in breastfed babies?
Actually, we have to know if the mother is if the neonate has a constipation or not. Because usually the mother comes and tells you that my child is constipated, he is not passing motion, every week he passes once. This is not constipation. We should, like I mentioned, normal pattern of stool. So if the neonate is presenting with motion that is soft, but passing every once per week, we just reassure. However, if there is a history of very difficult passage of motion, very hard stool, there is fissure in an older age, like more than 3 months, we can use glycerin suppository. I usually all the cases I saw, I reassure them actually. And we can instruct the mother also, if she's breastfeeding, to keep herself also on high fiber diet and avoid her constipation herself.
I always wonder, why is constipation in children more common in mothers who are constipated?
Subhanallah, I think it is related to the breastfeeding and how the mother's health and her diet actually.
Okay. Question from Dr. Ali Ahmed to Dr. Ala. When do we send constipation to a surgeon? I think we have answered that. Question from Dr. Faisal to Dr. Ala. Do we do thyroid function and celiac disease profile from the second or third visit?
Actually, if the case is diagnosed as functional constipation by the wrong criteria and by clinical examination and a history obtaining, there is no recommendation to actually send for lab or diagnostic test. However, if the patient is not responding to the treatment or there is another symptoms like failure to thrive, we can think to send these tests. So it depends on the clinical context.
Okay. Dr. Hala is asking you, what about glycerin suppositories?
I think it's not clear what is the question actually. But anyways, we can use glycerin suppositories in infants below 1 year of age.
Okay.
If needed, if really needed.
Okay. Dr. Farhan is asking you, Dr. Ala, what is the best way to relieve constipation in infants and neonates, as nowadays glycerin suppositories are not available?
Actually, just instructions about diet. And in infants, actually in neonates, we said that we don't use medications actually. In regards to infants, if the diet is starting, we can advise them about the diet itself, what to give and what to avoid. And for the glycerin suppositories can be used, and because it's not available currently, there is some studies and published in the JBNGN about the use of Movicol in infancy. However, I need to read about that more.
Okay. Another question from Dr. Ali. What is the relationship between constipation and child abuse?
Actually, there is a relation. It's like stress and anxiety that can cause constipation. And also, if there is sexual abuse, the patient will be really afraid, not wanting to be examined, very phobia and fear of this examination of the anal area. So there is a relation, yes.
Okay, Dr. Hala is commenting here, and she says, in my clinic, I use probiotic in case of constipation and patients improve.
Okay, this is an observation. However, as I mentioned, there is no clear evidence. I think if the patient is improving, personally, I think no harm, but personally, I don't use this medication.
Okay.
Just briefly comment, Dr. Naufal.
تفضل.
Yeah, I totally agree with Dr. Ala. There is a lack of evidence for using probiotics and neonatal with constipation. However, I think it should be individualized. So, for example, the babies who are born as cesarean section, I think it might be worth to try if everything failed, which I mean by failed, the behavioral therapy, the reassurance of the maternal anxiety, especially with the mother who are shopping around in many polyclinics, bombarded with a lot of information from the pediatrician to change the formula. So that would create an anxiety by itself, and that would reflect or be reflected on the mother during the feeding. So that anxiety would be reflected also, I believe, on the baby. So no question, behavioral modifications is number one, which reduce the mother anxiety. And if that failed, then the most important thing is let them know, don't change the formula in case if they do not want to change, introduce or reintroduce the breast milk. Number three, the other remedy might be considered as I said, the probiotics, especially if the mother is, I mean, this is an observation, I know, but if that too fails, what can you do? You might introduce the probiotics as a trial, especially with the baby who was born with the cesarean section, because we know that they don't have any microbiome in their guts. Thank you.
Thank you.
Thank you. Another question for Dr. Ala from Dr. Wafa. Is it safe? What is the safest age to start fleet enema in children and infants? And are there indications?
I would start beyond the age of 1 year. And for contraindication, if there is any signs or symptoms of bowel obstruction, we don't use that medication. It's not a complete absolute contraindication, but if the patient has fissure, it will be difficult to use the fleet enema.
Another question to Dr. Tahani from Dr. Amani. Do you recommend home prescription of rectal anti-epileptic drugs to all epileptic children in case of an emergency?
It depends, actually, as we mentioned, how far they are from the hospital, nearest emergency department. The child, him, herself, whether they experienced a previous history of status epilepticus, these takes in consideration, actually.
Thank you.
Can I make a quick comment?
Dr. Hassan is asking Dr. Ala. Yes.
Naufal? If we are going to use rectal,
تفضل.
if we are going to teach the parents how to or to use rectal lorazepam or rectal diazepam, I think it's probably it's a common practice to teach them at least on how to do like a simple, you know, life saving, just in case if the child went to respiratory depression or anything. Is this the practice, Dr. Tahani?
Thank you, Dr. Twaim. Yes, actually, with explaining side effects also for the rescue anti-seizure medications as well. We have to explain that these also could, in simple terms, relax the body, relax the respiratory muscles as well. And as for that, if the patient has received it, he needs also to go to the ER. But because it's very essential, actually, because the underlying pathophysiology for seizure, we have a time zone. And this time zone, actually, in the first 5 minutes, we have certain medications to be used because the channels and all these things. And then afterwards, also for this time zone, also we have another use of another antiepileptic drugs, because subhanallah, these has a certain pathophysiology, and certain channels they close and certain channels they open, and for that we have for certain time medications to be used for the seizures. For this, actually, it's essential, and also other pediatricians, they prescribe if they see patients, and it's a rescue medication that is very helpful for most families, explaining to them how to use it, when to use it, and the side effects of it.
What medications are available rectally apart from diazepam?
We have, at the current time being, rectal diazepam in most of the hospitals used. We have the buccal midazolam, and in some rescue ambulance and first aid lines, the IM also kind of a route to be used. Sometimes we have in, it depends on the hospitals, actually.
But rectal drugs.
It's a big subject, Dr. Naufal. It has, many literature has been viewed. I reviewed the topic for status epilepticus, which is a huge, actually, topic, as we all know. And they have many studies compared the many routes for stopping the seizure. And of course, if we have IV line, it's good to give the patients an IV medication.
Yes, but the medications that are available rectally, as far as I know, there are only two: rectal diazepam and paraldehyde, which is now out of favor. Is that right?
Are
there any other medications?
Use rectal diazepam, as far as I know.
Yeah. Okay. Thank you. Dr. Ala, Dr. Hassan is asking you, is it useful to change to formula in infants suffering from constipation, as this has been the practice in a lot of private clinics? It's not clear whether he means change the formula in kids suffering from constipation in infants who are breastfed or in infants who are on bottle formula already.
I have noticed in the private clinical practice, yes, they change the formula. It's not helpful unless there is a diagnosis of cow's milk protein allergy by history and examination. Then I would recommend to change the formula, but otherwise, no.
Okay.
I would like, Doctor, I would like to really support Dr. Ala answer for this question. We always keep infant same formula. And في الحقيقة مشكلة البرايفت, they always advise the parents, the mother, to change from one formula to another, except if there is suspected cow milk allergy. The other thing, this media of different nutritional company on this formula for constipation. They all companies, they have this formula of constipation, which I don't think. How common we say excessive milk intake will cause constipation, and then we give formula for constipation. So I don't know whether somebody really had any experience with this formula, which is written for constipation, which I totally discourage it.
Maybe I add, Dr. Naufal.
تفضل تفضل حبيبي.
Just to let you know that we have 42 different formula in the Saudi market for babies, different companies. And I always say that all these formula is from the same cow. So this is maybe important for people to know about
I
this.
always tell them that the source is the same. It's the cow.
Thank you. Because of the
Thank
time
you.
now, you think
There
you can conclude?
Yes, there are 3 more questions. Do I leave them or?
Well, I think the organizer is telling me that the time is reaching. We can have one question if you want.
Yes. Okay. Question to Dr. Tahani from Dr. Bahji. Is it better to use buccal midazolam?
As I mentioned, it's actually depends on the route, and there are large studies that compared many. If you're happy, I can later share. You can review also and share what has been studied.
Okay. Thank you very much. I would like to conclude by thanking the organizer, thanking Dr. Abdul Mu'in, Professor Abdul Mu'in, and Professor Asiri, and Dr. Abdul Aziz, and all our excellent speakers for their excellent presentations, and also all the audience for their active contribution and very good questions presented. And we look forward to seeing you in another Jeddah Pediatric Club. Thank you and good night.
Thank you. Thank you.
Thank you all.